Systemic therapy for breast cancer, selective estrogen receptor modulator, is the first of your hormonal treatments. These are for premenopausal patients. They bind to the estrogen receptor and block estrogen from binding. The dose is typically tamoxifen 20 milligrams by mouth every day for 5 to 10 years. The role of tamoxifen in invasive cancer has a 5 to 10% overall survival benefit in invasive disease per the Oxford Review. This is independent on its effect on local control. The trial looking at this is NSABP B21, which is looking at size less than or equal to 1 centimeters after wide local excision. Any ER status was allowed. The patients are randomized either tamoxifen times 5 years alone, tamoxifen plus 50 gray, or 50 gray alone, and assess the 8-year ipsilateral breast tumor recurrence rates. For tamoxifen times 5 years alone, the 8-year ipsilateral breast tumor recurrence was 17% versus 3% for tamoxifen and 50 gray of radiation, and 9% versus 50 gray of radiation alone. At 14 years, this kind of washes out to the point where there's 29%, almost a 30% ipsilateral breast tumor recurrence rate with tamoxifen alone versus 10% and 11% for the combined tamoxifen and radiation versus radiation alone. The bottom line from NSABP B21 is that radiation and tamoxifen improve ipsilateral breast tumor recurrence in tumors less than or equal to 1 centimeter. At longer follow-up at 14 years, though, the ipsilateral breast tumor recurrence of tamoxifen added to radiation essentially disappears, becoming similar to that of radiation alone. Tamoxifen's role in DCIS is established by NSABP B24. 21 is for invasive disease, 24 is for DCIS. This looks at wide local excision for DCIS, including those with a positive margin. Again, any ER status is allowed at the time of the trial. Patients were randomized to 50 gray plus tamoxifen times 5 years versus 50 gray alone. A boost was given in over a third of the patients, 38.5%. There's a small benefit, absolute reduction by 3%, decrease of ipsilateral invasive recurrences, and contralateral in situ recurrences. UKCCR, aka UKANZ, is your second trial for DCIS and tamoxifen. Radiation decreases the incidence of all new breast events, ipsilateral invasive, and DCIS, but has no effect on contralateral disease. Again, radiation decreases the incidence of all new breast events, ipsilateral invasive, and DCIS. Tamoxifen decreases the incidence of all new breast events, ipsilateral DCIS, and contralateral tumors, but has no effect on ipsilateral invasive disease. So, difference there. Again, radiation has no effect on contralateral disease. Tamoxifen has no effect on ipsilateral invasive disease. Aromatase inhibitors like anastrozole are for postmenopausal patients. They prevent conversion via blocking androgen to estrone and estradiol. Non-steroidal are things like letrozole, which is Femara, and anastrozole, which is Arimidex, 2.5 milligrams. Steroidal are exemestane, formestane, which is Lenteron, used for invasive and for DCIS. It's okay to extrapolate to DCIS, even though the trials only use tamoxifen. Side effects for Arimidex postmenopausal, which is anastrozole, are going to be osteoporosis, joint pain, and even fracture in 5 to 7%. There are fewer embolic and endometrial cancers that increase risk of osteoporosis. Tamoxifen side effects are hot flashes, 30 to 40%, atrophy, vaginal bleeding, 5 to 10%, thromboembolic events, 2 to 5%, endometrial cancer. Chemotherapy is next. Chemo, premenopausal patients, there's a 10 to 15% 15-year overall survival and disease-specific survival benefit. For postmenopausal patients, that's decreased. There's a 5% 15-year overall survival and 15-year disease-specific survival benefit. Guidelines for usage. For triple negative, anything over 1 centimeter, you give it. You can consider it for anything that's larger than half a centimeter in size. You consider it for HER2 positive, ER/PR negative, greater than a half a centimeter. You give it for 1 centimeter. The only difference here, the one where you're more conservative and you give it rather than consider it for over half a centimeter, is a triple positive. Oncotype testing, anything that's 0.5 to 5 centimeters in size that is ER/PR positive, HER2 negative, and node negative. This is a 21 gene assay developed and validated from NSABP tissue banks. It assesses the risk of distant recurrence with tamoxifen alone, categorized into low risk, intermediate risk, and high risk. Low risk is anything from 1 to 18. I remember this by 18 is the legal age. And the risk of distant recurrence is 7%. Intermediate is 19 to 30. The distant risk is 14%. And this group was studied in the Taylor RX and RX Ponder trials. Then high risk is greater than 30. A distant recurrence risk is 30%. Each risk essentially doubles, so you go from 7 to 14 to 30. Again, 1 to 18, 19 to 30, and greater than 30. The Taylor RX trial essentially looked at this intermediate risk group for ER/PR positive, HER2 negative, node negative with an intermediate oncotype score of 11 to 25. So they did not go beyond 25. These patients were randomized to chemotherapy and endocrine therapy versus endocrine therapy alone. And then high oncotype, anything over 25 within this intermediate risk group, was just given chemotherapy and endocrine therapy. The results, there was no change in 9-year overall survival, distant METs, disease-free survival, or local regional recurrence. The bottom line is that adding chemo to just endocrine therapy does not improve outcomes when added to endocrine treatment in this intermediate risk oncotype. Chemo and endo alone actually both caused a significant cognitive decline. There was a post-hoc sub-analysis that showed that chemo might benefit patients that are young, less than 50, with high-risk tumors. It was very weird that they did that sub-analysis, given the fact that the oncotype is supposed to be supplanting anything about clinical factors. Anyway, the next trial is RX Ponder, again looking at the role of chemotherapy in this intermediate risk oncotype group, but with the exception that they had 1 to 3 nodes. These were about 9,300 ER/PR positive, HER2 negative, 1 to 3 nodes positive breast cancers, meaning that they were N1A. They had an oncotype recurrence score of, again, less than or equal to 25. They're randomized, again, to basically chemo plus endocrine treatment versus endocrine treatment alone. The results, the postmenopausal ipsilateral disease-free survival was no different. Bottom line is that chemo and ER/PR positive postmenopausal women with 1 to 3 nodes positive produced no ipsilateral disease-free survival or overall survival benefit, can be avoided, but it does actually lead to an ipsilateral disease-free survival benefit in premenopausal women. Chemo regimens that are important to be aware of. Dose-dense regimens have increased efficacy. AC times 4 followed by T times 4. This is your AC plus T regimen. AC is adriamycin, cyclophosphamide, and T is Taxol, which is paclitaxel. AC is every 3 weeks or every 2 weeks if it's dose-dense, and then T is every 2 weeks or weekly times 12 weeks after AC if it's dose-dense. Adriamycin's dose is 60 milligrams per meter squared. Cyclophosphamide or Cytoxan's dose is just 10 times that at 600 milligrams per meter squared. And Taxol is 175 milligrams per meter squared, which is the every 2-week dose. Again, AC times 4 followed by T times 4. AC every 3 weeks, every 2 weeks if it's dose dense. T is every 2 weeks or weekly times 12 after AC. Adriamycin, cyclophosphamide, Taxol. Adriamycin 60, cyclophosphamide 600, Taxol 175. Your other option is TC times 6, which is Taxotere, which is different. It's not the same as paclitaxel, and cyclophosphamide, which is the same. You can consider if the patient has cardiac issues and you want to avoid adriamycin. Taxotere, which is docetaxel, is 75 milligrams per meter squared, and cyclophosphamide, Cytoxan, is again 600 milligrams per meter squared. AC followed by TH, it's the same as AC plus T, except paclitaxel dose is lower. It's 80 milligrams per meter squared. This is a weekly dose. Herceptin's dose is 4 milligrams per kilogram on week 1, 2 milligrams per kilogram weekly until completion of 1 year, or 6 milligrams per kilogram every 21 days until the completion of 1 year. Plus or minus pertuzumab, only approved in neoadjuvant setting, must go on trial for adjuvant. TCH plus or minus pertuzumab for low-risk HER2, only indication for chemo. TCHP with carboplatin is the most common contemporary neoadjuvant chemo for HER2-positive breast cancer per the Christine trial. Taxotere 75, carboplatin area under the curve 6, Herceptin 8 to 6, and then pertuzumab 840 to 420 every 3 weeks up to 18 cycles. 6 cycles are given neoadjuvantly. Adjuvant chemotherapy in HER2 positive and triple negative with residual disease. TDM1 improves 3-year disease-free survival by 10% over trastuzumab for HER2 positive breast cancers with residual disease after neoadjuvant chemo for the Catherine. You do not offer TDM1 to patients with a path CR to chemo. Capecitabine improves 5-year overall survival by approximately 5% for HER2 negative disease. 10% for triple negative breast cancer with residual disease after neoadjuvant chemo. This is the CREATE-X trial. Trastuzumab plus docetaxel plus pertuzumab improves overall survival in metastatic HER2 positive breast cancer from 23% to 37% for the Cleopatra trial. The CALOR trial looks at the role of chemo in recurrence. All recurrent breast cancers after radical resection were randomized to chemo or no chemo. The 5-year overall survival was 88% with chemo versus 76% without. 5-year disease-free survival was 67% versus 35%. There was a benefit here for ER negative but not ER positive at 9 years. An endocrine treatment was given. For hormone receptor positive for HER2, it was optional. Bottom line from CALOR is chemo improves overall survival in ER negative locally recurrent breast cancers. ER positive patients could be managed with hormonal treatment alone. In terms of toxicities to Herceptin, cardiotoxicity is the biggest one. You watch the heart dose, try to avoid IMN coverage. There's a decreased risk of recurrence and increased survival. Cardiac monitoring at baseline 3, 6, and 9 months. AC plus T, you worry about myelosuppression. Adriamycin can cause hair loss and again cardiac issues.